It is my pleasure to introduce Dr. Jason Cobb. He is an adult nephrologist and assistant professor of medicine in the Emory University Division of Renal Medicine. Dr. Cobb is a graduate of Morehouse College with a BS in biology. He holds a medical degree from Emory University School of Medicine and completed his internal medicine residency and nephrology fellowship at Emory University. He is board certified in internal medicine and nephrology. He sees patients in the nephrology clinic at Emory University with nephrology complaints such as chronic kidney disease due to diabetes, hypertension, vascular disease, and glomerulonephritis. And I hope I said that right.
Yes.
Thank you so much, Dr. Cobb, for being here. And I will let you take over now as you share your slides.
Thank you so much for the invitation in the introduction. Savannah, feel free to manage the chat and interrupt me if someone has a question that needs to be answered right away or during that particular topic.
Sure.
I will not be using the whole hour, so there definitely will be time for questions at the end also. So the basics of glomerular disease. Also has my social media. If y'all on social media, feel free. Jason Cobb MD on Twitter. Research funding, financial disclosures. We have a summer program in nephrology. I'm a co-investigator, which is ran by the National Institute of Health. And also we have a lupus nephritis biomarker trial that we're actively enrolling patients for. Also have a dialysis study from AHRQ, which is another government agency. And industry, Vertex, co-investigator for the Fsgs and APOL1 study. And some consulting with the American College of Rheumatology and lupus nephritis work. So we're gonna do kidney anatomy on the bit basis. So 99.9% of us are born with two kidneys, one on your left and one on your right. Then you have your ureter, which takes urine from the kidney down to the bladder. Then the urine is excreted. We think about the kidney in two ways. You got the medulla, which is the inner portion of the kidney, and you have your cortex, which is the outer portion of the kidney. When we try to make diagnosis for glomerulonephritis, glomerular disease, it's the outer portion, the cortex, that has the most information, and that's what we try to attain when we do the kidney biopsy. The glomerulus. So this is, the nephron is the functioning unit of the kidney, but the important part is the glomerulus. This is where the filtration happens. So a lot of things such as blood and protein, it's supposed to be in your blood vessels. It should not be in your urine. So we have problems in the glomerulus, and we have problems with the filtration barrier, and you start leaking protein, and you start leaking blood into your urine. And that's how we determine which type of glomerular disease someone has. The glomerulus, we call it glomeruli when we talk about multiple. There's around 1 million glomeruli in each kidney. So we have the afferent arteriole, where blood is going into the kidney of the glomerulus, and you have the efferent arteriole, where blood is leaving the glomerulus. And we will talk about a lot today, podocytes. These are the little areas around this blood vessel that has a lot to do with that filtration barrier. This is looking at it at a more microscopic level. You have your glomerular basement membrane. And on the epithelial side, you have your foot processes. We talk about the podocyte, but then you have these little foot processes, and you have the other little barriers between each foot process. And this is important. This is what keeps things from filtering into your urine. It should be in your blood, the protein in the blood. It shouldn't be in your urine. So when we have glomerular disease or glomerulonephritis, we have issues on the endothelial side, the glomerular basement membrane side, or with the foot processes and the podocyte. Somewhere in that barrier is not maintained, and that's how we get protein and blood in your urine. So, as Savannah mentioned earlier, I have an interest in glomerulonephritis. The body does not read the textbooks. But the majority of the time when we talk about glomerulonephritis, we divide it into two categories. You have nephritis syndrome, which mostly deal with protein leaking into the urine. Then you have nephritis syndrome, which mostly deals with more blood leaking into the urine. But oftentimes you see a combination of both protein and blood when we talk about glomerulonephritis, is the body does not read the textbooks. Labs one-on-one, and this is something I want all my patients to be familiar with their labs. I want my patients to follow up with their labs so we can have a talk about it each time, and they know where they're going, if things are improving or things are worsening. I don't want them just to trust me. I want this to be an informed thing where we both are educated about where they are right now and what's going on with their kidneys. So we ordered the chemistry. So Chem 8 or Chem 14, which we call the basic metabolic panel or the comprehensive metabolic panel. And both of those include your serum creatinine. So we all have muscle mass, and muscle has creatine. That's broken down to creatinine. So this is how we determine your kidney function. Your kidneys, when they're working properly, gets rid of the creatinine in your blood and spill into the urine. It excretes it from the body. So having a low creatinine in your blood is a good thing. So most people have a serum creatinine or less than 1 or less is considered normal kidney function. We put this creatinine into an equation. You don't have to do the math. Most medical centers now will calculate it for you and put it on your lab report. And it says the estimated glomerular filtration rate, or your GFR. Normal is above 100% or above 100. So I usually tell my patients to remember, it's harder for patients to remember the creatinine, but patients usually can remember the GFR. So they know if I can tell them they have normal kidney function, if their kidney function is at 70% or is at 40% or is down to 15%, most patients can remember that. So if they go to an emergency department or another hospital, usually my patient can tell the other provider where their kidney function percent is, so they'll know some type of baseline. One thing I am involved with is diversity and inclusion efforts. A lot of places will report the estimated glomerular filtration rate, or eGFR, for Black patients versus everyone else. So this has been a big topic in public policy when it comes to nephrology. A lot of centers are getting rid of that, and here at Emory, we just approved it also. So hopefully in the near future, most places will be reporting the GFR as one value and not doing race-based kidney function reporting. The urinalysis. So we talk about the blood work and your creatinine. Next part is your urinalysis. So I look at especially my new patients, I look at their urine under the microscope every time. And patients that I need to keep track of their urine microscopy, I keep looking at their urine under the microscope. So two things that we can tell from the urine is how much blood you're spilling or how much protein you're spilling. So in clinic, I can do a quick dipstick and right away, it will say 1+ blood or 3+ protein. But I had to send that sample to the lab to get more in-depth analysis. So one way when it comes to the protein, to figure out exactly how much protein you're spilling per day, we can do a 24-hour urine protein. That could be kind of cumbersome though. You most likely have to be at home that day. Most likely we will tell you to keep the urine cool, keep it in a safe place, sometimes your refrigerator or away from other people. But also it could be hard if we're trying to track your urine protein over a period of time to keep doing the 24-hour urine. Most of the time we can get away with a spot urine protein creatinine ratio. So we send that initial urine sample to the lab and it will give us a value for the protein and a value for the creatinine. And I would do a ratio. Let's say if your protein is 300 milligrams and your creatinine is 100 milligrams, and you do a ratio of those two, that's about 3 grams or 3,000 milligrams of protein per day. So the spot urine protein creatinine ratio is a pretty good estimate of how much protein you're spilling in a day. You don't have to do 24-hour urines every time. So nephritis syndrome, dealing more with protein in the urine. So urine excretion more than 3.5 grams or 3,500 milligrams of protein per day. And so you can have nephrotic range proteinuria where you spill a lot of protein in your urine, but you don't have some of the other side effects. So when we talk about the syndrome, we're talking about the complete side effects. So you spill a lot of protein in your urine, nephritis range proteinuria, edema or swelling. That protein is supposed to be in your blood. not in the space outside your blood vessels, not in your urine. So when that's happened, a lot of patients will get edema or swelling into their, especially their lower legs. And if the process get worse, it'll go into the abdomen, and if the process get even worse, patients will get fluid in their lungs, which is a bad sign. And usually patients need to be admitted to the hospital for that. Hypoalbumin anemia, that means you have a low protein in your blood because you're spilling a lot of protein in your urine. So besides looking at the protein in the urine, I also can look at the protein in the blood, the albumin, and keep track and see if a patient is getting worse or a patient is improving. Hyperlipidemia, high cholesterol levels. So when you lose the protein in your blood vessels, the majority of the protein in your body, the albumin, is made in the liver. So what the liver will do to try to compensate will crank up the amount of cholesterol it's producing. So I tell a lot of my nephritis syndrome patients, you know, your cholesterol is high, and they say, I'm eating right and I'm doing the best I can. It's your liver compensating for the protein loss while the cholesterol is so high. So sometimes I have to put my nephritis syndrome patients on cholesterol medications. A lot of times it's just temporary. As your body responds to the treatment for the protein in the urine and you spill less protein in your urine, the cholesterol will often get better, and I can wean my patients off the cholesterol medications. Patients with nephritis syndrome can also be hypercoagulable. That means they're at a higher risk of clotting. Just like you losing the protein from your blood in the urine, you also lose some of the things that make your blood clot. So your clotting factors like antithrombin 3, it could be lost in the urine in nephritis syndrome. And some patients with nephritis syndrome will get clots such as DVTs or deep vein thrombosis in their legs, or even PEs, emboli or thrombosis or clots in their lungs. The major causes of nephritis syndrome. Membranous nephropathy. Okay, so one thing in nephrology, we did not make it easy for people who want to, we have a lack of interest of people going into nephrology, and as nephrologists, we didn't make it easy by the names that we came up for a lot of our disease processes. So bear with me with the names. Even yourself, sometimes it could be hard to remember exactly. Sometimes you can give me the abbreviation. So membranous nephropathy, focal segmental glomerulosclerosis, or FSGS. Some subtypes of FSGS and minimal change are like C1q nephropathy, IgM nephropathy, minimal change disease, IgA nephropathy, membranoproliferative glomerulonephritis, MPGN, and a subtype of that could be C3 glomerulonephritis. Now, the most common cause of nephritis syndrome in kidney disease in the United States is diabetic nephropathy. But that's not something we are concentrating on today. It's not one of the NephCure main areas. Some things that we need help with from my hematology and oncology friends, amyloidosis and multiple myeloma can cause nephritis syndrome. And an area I see a lot too is lupus nephritis, where we work a lot with our rheumatology cohorts. But the ones in the red are the ones that we really go concentrate on today. Membranous nephropathy, FSGS, focal segmental glomerulosclerosis, minimal change disease, IgA nephropathy, and MBGN, membranoproliferative glomerulonephritis. So how you diagnose glomerulonephritis? Renal, kidney biopsy. This is how I distinguish a primary glomerular disease and exclude it from a secondary glomerular disease. As I mentioned earlier, what really got me interested in nephrology, and especially glomerulonephritis, was my internal medicine residency days at Emory. We work out of a public hospital, Greater Memorial Hospital. We see a lot of HIV and lupus patients in that hospital, and a lot of them will develop glomerulonephritis. But those are not primary glomerular diseases. Those are secondary to the disease process, and we won't be focusing on that with NephCure. But that got me interested in glomerulonephritis because your exposure as a medical student is on different types of nephrology. It's not really a lot on glomerulonephritis, but that really got me interested. So now I'm interested in primary and secondary causes of glomerular disease or glomerulonephritis. And while we need to distinguish this from the kidney biopsy, there's a bunch of things that we called out already today, but the treatment for each one is different. And also the treatment between each one is different if it's primary or it's a secondary. So primary glomerular diseases, unfortunately, just happen. It's usually not something that you did that caused that. We call those idiopathic also. But unfortunately though, there's work being done and research being done that we actually might figure out the reason why for some of these diseases. But the treatment for primary versus secondary is a lot different a lot of times, and especially with the secondary ones, you don't usually need a lot of immunosuppression medications. So that's why it's important to get the kidney biopsy, and so you can distinguish, so we can determine exactly what you have and come up with a treatment plan specifically for you. Another thing for the kidney biopsy, I like to tell patients, is determine the disease for severity. How much of the kidney involved? So with the blood work that we do, the creatinine, I can tell how your kidney is doing when it comes to filtering your blood from the creatinine. But it does not tell me specifically, though, how much of your kidney is being involved. Because some of these glomerular diseases, you'll have a normal kidney function, but you'll have a lot of protein and a lot of blood in your urine. But when I do the biopsy, it'll tell me that you have 40% of your kidney involved with FSGS, or 60% of your kidney involved with membranous nephropathy. And that's really important to see how much is being involved, or how severe your glomerular nephritis or glomerular disease is. Because sometimes, unfortunately, I had a patient just recently. She has FSGS, but she had 85% scarring on her kidney biopsy. So somebody who has 85% scarring, she only has 15% of viable kidney left. So somebody like that, you do not want to, you think about risk versus benefit. You do not want to give a lot of high dose immunosuppression to that medication, to that patient. And you got to think about the side effects of those medications when the patient only has about 10 or 15% of her kidney that's actually left. The rest of it is scarred. So the amount of scarring, disease severity is very important. We can get that from the kidney biopsy. So useful for establishing and confirming a diagnosis, and determine the degree of inflammation and fibrosis. And when I mean fibrosis, we're just talking about scarring. So types of kidney disease. This was a study in the late 90s, and the most common glomerulonephritis was membranous nephropathy, which was pretty much tied with FSGS, focal segmental glomerulosclerosis. And these were looking at adults. 15% minimal change disease. In pediatrics, minimal change disease would be number one, not in adults. 4% in this study was amyloid, but there was a big difference as they looked at their hospital from the 1970s to the late 1990s. FSGS had moved from being toward the bottom as being toward the top. A lot of this because possibly some genetics, but possibly some of the things that cause secondary causes of FSGS were not around in the 1970s, such as HIV. Also, obesity pandemic in the country has been associated with FSGS, and that's definitely worse now compared to like the 1970s. So FSGS is moving up, and I would argue at a place like I work in Emory, which is in the urban patient population in Atlanta, the FSGS is our number one, is above membranous, depending on where you are and what patient population you see. So minimal change disease. Common in children. Incident decreases with older age. So I'm an adult nephrologist, but I'm actively seeing right now 2 patients with minimal change disease. They're both in their 20s. So even though it happens more commonly in children, and it does decrease as you get older, and as an adult nephrologist, you have 2 active patients right now in their 20s being treated for minimal change disease. It could be idiopathic, it just happens, or it could be secondary to other causes. Pure nephritis syndrome with normal kidney function, which is a good thing, that most of the time the kidney function, the serum creatinine is normal in most patients with minimal change disease, but they're just spilling a lot of protein in their urine. Kidney biopsy is normal on light microscopy. So it takes nephrology fellows 2 years of training to learn kidney pathology. So we do not expect you to know kidney pathology in a 40-minute talk. But to the here is your light microscopy. And so when I do the kidney biopsy and we turn it into the pathologist, they give us 3 things. They give us a light microscopy, the electron microscopy, and the immunofluorescence. This picture has a light microscopy here. Minimal change disease, the reason why we call it minimal change disease, it actually looks pretty normal. There's not many changes on the light microscopy. But the electron microscopy, this is where you see the big changes in minimal change disease. So the top is a normal one. Like I was showing earlier, you have your foot processes and you have your little slits in between. This is pretty normal. The below one is a patient with minimal change disease, or FSGS, where they have, as you can see, the foot processes have pretty much gone away. They efface, we call that effacement, and they're not normal. So now protein is spilling into the urine. So that's why patients with minimal change disease get nephritis syndrome and spill a lot of protein in their urine. Treatment. As the question came up earlier, unfortunately, we do use a lot of steroids, most commonly prednisone, in a lot of kidney diseases, in the glomerular nephritis syndrome space. Minimal in our guidelines, still for a lot of these things, steroids are the first line treatment. Minimal change disease, steroids first line treatment. Prednisone, we usually give 1 milligram per kilogram per day, so doing it based on your weight. Once remission occurred, though, you can taper. Usually I will give patients about 16 weeks to 4 months before we'll say that if they're not responding, before we'll call them a treatment failure. Then you got secondary agents, so like calcineurin inhibitors like tacrolimus or Prograf, cyclosporin. So as an adult nephrologist, we also see a lot of kidney transplant patients. So a lot of things that we use in kidney transplant, such as Prograf and cyclosporin, we also use for diseases such as minimal change disease and FSGS. Some secondary agents, so first line is steroids. Second line for me would be Prograf or cyclosporin. I'm more of a Prograf fan personally. Then on another level, you can start seeing rituximab and mycophenolate. I would have to say there's some studies, especially in pediatric population, that rituximab might be moving up on the recommendations in recurrent relapse and minimal change disease in pediatric population. Actually, one of the patients I've seen in his 20s, he did not respond well to steroids, and we tried some of the other medications, and he had side effects. I think he had very high blood pressure with Prograf. But rituximab, he's been doing well. He's not a pediatric patient. He's in his late 20s, but he's responding very well with rituximab, and he's getting rituximab every 6 months. Mycophenolate, another drug that I use a lot between my lupus nephritis patients and my kidney transplant patients. They all use mycophenolate a lot. They also could be a possible agent for minimal change disease also. So especially contraindication to steroids, if a patient becomes steroid dependent, you can't have patients on high doses of steroids for 2 or 3 years straight. So some of these patients need high dose steroids. They'll respond to treatment, but when you wean the steroids off, they'll relapse. So you need to probably think about some of these secondary agents in those steroid dependent or patients, or people who have frequent relapses. And that's why I'm glad some of the newer studies are showing some added benefits for some of the secondary agents. Focal segmental glomerulosclerosis, FSGS, idiopathic, it just happens, or it could be secondary. Nephrotic range proteinuria, more than 3.5 grams or 3,500 milligrams of protein per day. And it's in focal segmental pattern. That's why we call it focal segmental. Unfortunately, though, patients with FSGS are usually sicker than patients with minimal change disease. About a third of patients with FSGS will have decreased kidney function when they first present. Hypertension is common. Minimal change disease, blood pressure not usually as high, but FSGS, a lot of times the blood pressure will increase in these patients. And definitely more common in African Americans. I will talk about this later today too, but ApoL1, a gene we think associated with FSGS, more and more data is coming out. And that's why we need more people to go into nephrology, to be interested in researching nephrology and things like FSGS. When I was a fellow, I've been in practice for 10 years now, so 12, 13 years ago, we were talking about myosin heavy chain 9. We think that's the gene associated with FSGS. It actually was a couple of rows down on the same chromosome. It ended up being ApoL1. So people, this is a new thing in nephrology, and people doing research, and I think we have to write one with ApoL1 being high association of FSGS, especially in African American patients. And also, there might be some things on prognosis. ApoL1 associated FSGS might be more severe or respond less to regular treatment compared to FSGS patients without ApoL1. So going back to some of the biopsy. So just like I said with minimal change disease, you have the normal foot processes, looks nice. But it's the effacement, which you see in minimal change in FSGS, which is abnormal. And this is when you start seeing the protein spill in the urine. It could be partial or patchy, or it could be complete, where the whole glomerulus, the whole kidney, is involved in this process. A is showing a normal patient again. You got the foot processes and you got the normal little slits in between. B is showing someone with a genetic disorder with a potassium or nephrin protein abnormality. And C and D also showing. So C is more of a complete, where it's completely involved, whereas D is a little more patchy. These are both patients with minimal change disease. So FSGS, we get the kidney biopsy back. There are multiple types of FSGS. So you got, like I said, in nephrology, we don't make it easy for you. Why we don't call it type 1, 2, 3, or 4, or A, B, C, or D. We got funny names for each one. You got perihilar, you got tip lesion, you got collapsing, and you have cellular. Only thing I'd like to say on this one, tip lesion are usually the best prognosis. So if you don't want to have FSGS, but if you do, if you have this type, the tip lesion, probably better response to steroids. As we know, the collapsing variant of FSGS is the one with the worst prognosis. These patients definitely have more severe kidney disease, could be more rapidly progressive, could be more resistant to steroids and other treatment agents. I will only talk about the secondary things briefly, because the pathologists give you a kidney biopsy back. It gives you the diagnosis. It says minimal change disease. It says FSGS. But it's really up to the nephrologist to try to determine this is a primary idiopathic or is secondary to something else. I just want patients to be informed. So some secondary things, pomidronate, which is an old osteoporosis treatment, some IV drug use, infections such as HIV-associated nephropathy or HIVAN, which is a collapsing FSGS, and really got me excited about glomerular nephritis in my early years. A new one that we've been seeing right now, COVID-19 associated FSGS. Oligonephronia. So that's a fancy word for saying somebody who has part of their kidney missing. So they had a partial nephrectomy. They get high filtration of that part of the kidney as that kidney try to make up for part of the kidney that lost, and they can get a secondary FSGS. Sickle cell, morbid obesity, lupus, hypertension can all be associated with secondary cause of FSGS. And the reason I bring these up, we want patients to be informed, but also if you have a secondary one, the treatment is a lot of times a lot different than idiopathic or primary. And COVID-19 associated glomerular disease, I've actually seen 2 cases myself on hospital service at Emory University Hospital, Midtown. But this is a study. They looked at 6 patients with COVID, and we have been extremely busy with COVID affecting the kidneys. But some of these patients had a lot of protein in the urine. So these researchers did kidney biopsies on these patients. And they ended up noticing that these patients had collapsing glomerulopathy, which is another way of saying collapsing FSGS. And they also did, out of the 6 patients, they did gene testing on 3 of the patients. And all 3 of those patients that were tested had high-risk APOL1 genotype. So the high-risk mutations for APOL1 that we know now is associated with kidney disease in African Americans, especially FSGS. So not surprising, but very interesting research that just came out this year with COVID. So the relationship between minimal change disease and FSGS. So a lot of people will tell you that minimal change in FSGS might be a spectrum, that minimal change is the less severe, then as it gets severe, it's FSGS. They definitely have similar pathology. They look very similar to each other on the kidney biopsy. Similar clinical characteristics, except for FSGS patients are usually more sicker with more abnormal kidney function. But some people say it might be a spectrum. Also, there's a thought about kidney biopsy sampling error. So you got 1 million glomeruli in each kidney, but when we do a biopsy, we only are usually happy if we get only 10 glomeruli. If you can get 30 or 40 glomeruli, I'm extremely happy. So are we just missing part of the kidney that we call minimal change disease, and they really might be FSGS, or is there some kidney biopsy sampling? And are we underdiagnosing FSGS in children? The reason that come up in adults, the first line thing for most adults is going to get a kidney biopsy if you have some type of glomerular disease. Where in kids, because minimal change is so high on the list compared to others, usually they'll treat kids with steroids first, And if you don't respond, then you'll get a kidney biopsy. So maybe we underdiagnose an FSGS in children, just saying a lot of these kids have minimal change disease and they get steroids right away without ever getting a kidney biopsy. So just talking about the relationship between minimal change and FSGS. FSGS and genetics, 2/3 of patients like neonatal associated with genetic defect. You got the phenotype congenital nephritis syndrome, NPHS1 and NPHS2, which is the podosin mutations. And unfortunately, these genetic mutations can run in families, and also they could be resistant to treatment. This was big in the New England Journal of Medicine in 2013, when this is the first big report talking about APOL1 being the possible gene defect associated with African Americans and kidney disease. APOL1 have emerged as a risk factor for end-stage kidney disease among African Americans, and having the G1 or G2 variants are the ones which were originally thought to be protection against African sleeping sickness, Trypanosoma brucei. But now, unfortunately, this mutation has been associated with kidney disease. And this is a picture that shows the spectrum. So things that are not so much associated with APOL1, we think things like IgA nephropathy. But as you see, you start really getting chronic kidney disease related to non-diabetic kidney disease, really high. Lupus nephritis with kidney failure is high. Dialysis overall is high. FSGS, 17 times the risk factor of having FSGS if you have the APOL1 gene defect. HIV-associated nephropathy, which is a secondary FSGS, 29 times the odds rate of getting HIV-associated nephropathy if you have the the APOL1 mutation. The interferon-associated FSGS, which is a specific type of FSGS, is extremely high in those patients. So APOL1 is is probably going to be the thing we focus on with FSGS and kidney disease in African Americans. FSGS treatment is pretty similar to minimal change disease treatment. Prednisone or steroids is the main thing. Usually treat for about 6 months if somebody responds completely. If you don't respond completely, then we might have to treat longer or move to second-line agents. So again, looking just like the minimal change disease slide, Prograf, cyclosporin, possibly cyclophosphamide, cytoxan, rituximab, mycophenolate or CellCept, ACTH, Actar. You don't see it advertised as much as you used to. Another possible second-line, third-line agent for FSGS. And especially with steroid resistant or somebody who have contraindications of steroids. You might ask, who is somebody with contraindications of steroids? Somebody with extreme obesity. A side effect of steroids is definitely weight gain. So that might be a patient that you might not do high doses of steroids in. Somebody with uncontrolled diabetes, a side effect of steroids could be elevated blood sugar. So that also might be a reason why we don't use steroids in some patients and do more to use a lower dose of steroids and add a second-line agent, or completely skip steroids and go to one of the second or third-line agents. This is important though. FSGS remission help determine the prognosis. So you respond to therapy, that's a good sign. People who do not respond as much, their kidney survival is a lot less, and that means possibly needing dialysis in the future. Now, minimal change disease in FSGS, we have some possible variants. When I was in fellowship 11 or 12 years ago, we might have brought up C1q nephropathy just a little bit, but now you're seeing more and more cases of this. So IgM nephropathy and C1q nephropathy. Both are very similar to minimal change disease in FSGS, what we see on the kidney biopsy, on the light microscopy, and the electron microscopy. But it's the immunofluorescence. This is lighting up light, bright green. This is where it's different in IgM and C1q. So IgM nephropathy patients will light up with IgM, and patients with C1q will light up with C1q. They both have a worsening prognosis compared to minimal change in FSGS. Membranous nephropathy. Idiopathic is most common. And in a lot of centers, membranous is going to be right up there with FSGS and what they see in the rare glomerular diseases. But I think in our institution at Emory, we probably see more FSGS. But membranous nephropathy, it can be idiopathic, just happens. You have some secondary causes, drugs such as NSAIDs. So these are non-steroidal such as Motrin, Abbott, Elite, Goody powder, BC powders. Infections such as hepatitis B and syphilis and HIV. Malignancy, lung, stomach, breast, bladder, especially in older patients with membranous. I just went through this myself. So we had a patient, he came to me in around August. We did a kidney biopsy. It came back membranous, but he's older. He's in his 60s. We really were trying to make sure we weren't missing a secondary cause of membranous, such as malignancy, such as cancer. Autoimmune, lupus, class 5 lupus nephritis is membranous. Clinical characteristics of membranous nephropathy. Majority of the patients going to have protein in the urine. 20 or 30% of patients could have a spontaneous remission. I mean, it just goes away. So that might be, that's important when we talk about the treatment of membranous nephropathy. It can relapse, it can remit. Usually normal blood pressure and creatinine at presentation, which is a good thing. Could be complete or partial remission. Younger patients rule out lupus, and children also make sure you rule out hepatitis, especially hepatitis B. Males more than females, and more in Caucasian patients. But this is the one which has the highest risk of clotting concerns. So I really worry about this. So my patient who was diagnosed in August, not responding to therapy, in March, unfortunately, he developed a clot in his lower leg. So here's a question. Which of the following is most likely in a patient with a diagnosis of idiopathic, primary, it just happened, membranous nephropathy? If some people could even type into the chat if they like. Antibodies to double-stranded DNA, which is a lupus test. Presence of hepatitis B surface antigen, which is a test for hepatitis B. RPR positive, which is a syphilis test. Antibodies to M-type phospholipase A2 receptor. Like I said in nephrology, we don't make it easy on names, but we call that PLAR. Or morbid obesity.
I think you might just have to tell us, Dr. Cobb.
I have to tell them, like, okay.
Okay.
With my fellow, I would not move to the next slide until I got some answers, but we'll move on. Antibodies
I think this question's so hard that they might be afraid to answer.
I understand. Antibodies to M-type phospholipase A2 receptor, or PLAR. So this is a big deal in nephrology. This was a landmark study in New England Journal of Medicine in 2009. M-type phospholipase A2 receptor is the target antigen in idiopathic membranous nephropathy. We actually think we know the protein or the antigen that the body is attacking in the kidney, which causes membranous nephropathy. This is the first kidney disease of this type that we know the answer to specifically. APOL1 and FSGS, we know the gene that might be causing it, but we don't know specifically what it's attacking in the kidney. Whereas in membranous, we know that PLAR, the phospholipase A2 receptor, is the target antigen. So we say PLAR antibodies seen in about 70% of patients with primary membranous. My patient, who I've talked about in August, he was PLAR negative, but we ended up testing. He had thrombospondin type 1 domain containing 7A antibodies. We don't make the names easy at all. So it's about 3% of cases with membranous. So my patient had the thrombospondin genetic mutation. Neutral endopeptidase antibodies. This is usually more in pediatric cases of membranous, antibodies to that. So how do you diagnose someone with membranous? So 10 years ago, the question was, the answer for this was always a kidney biopsy. It's a little, there might be a little debate these days. So our guidelines, myself, still recommend kidney biopsy, anti-PLAR, the way I just talked about, the antibodies to PLAR. It's only positive in about 70% of cases of idiopathic membranous. But some people are saying that we might go to a serologic-based approach. If you're in a patient population that has a lot of membranous, that's the number one thing you see in your patient population, maybe so. But at Emory, we definitely probably see more FSGS than we see membranous. I still think kidney biopsies are very important too, because it tells you information such as how much scarring that the patient might have, how much of the kidney is actually involved in the disease process. So there are some people who say you might test for PLAR first. If it comes back positive, treat the patient like they have idiopathic membranous. If they respond, never need a kidney biopsy. If they respond, then you might need a kidney biopsy. I'm not quite there yet. I still think we need a kidney biopsy first. As a slide I showed you in another patient population in the study, it was only 33% of their patients that were membranous nephropathy. And my patient, who definitely has idiopathic or primary membranous right now, he was anti-PLAR negative. He ended up having the other rarer antithrombospondin defect. And also, the PLAR testing is not that cheap, and also it might not be available at all centers as a special test. Membranous treatment, because we said 20 or 30% might have spontaneous remission or get better on their own. A lot of times, if the patient is stable, we would just do blood pressure medication treatment, diet modification, and give the patient 6 months. That's how we did my patient in August originally. As he started to decline, as we got closer to around Christmas or New Year's, he ended up needing immunosuppression medication. If the patient not responding with just blood pressure medication control and diet modification, then you could consider more immunosuppression. Also, patients who have a very low protein in their urine and spilling a lot of protein and risk of clotting, you might even think about prevention or blood clots or giving anticoagulation to those patients. Myself, I give everyone, put them on aspirin after they finish the kidney biopsy and not risk of bleeding, but usually I won't give more severe anticoagulation until they might have a complication. First line therapy, usually cyclophosphamide, or Cytoxan, usually it's oral cyclophosphamide. But now, that's why people do research in nephrology. We had a landmark trial using rituximab that came out in 2020, and they use a lot less steroids in that study too. But with the Cytoxan or cyclophosphamide, usually you give high-dose prednisone along with the cyclophosphamide. Possibly with the rituximab trial, which I'm very happy about, we can get away with less steroids. Second-line agents would be tacrolimus, or Prograf, and cyclosporin. So Mentor trial, New England Journal of Medicine in 2020, 130 patients. You was like, that's not a lot of people. Things like membranous are pretty rare. So actually 130 patients in a membranous trial is a lot. And they compare rituximab to cyclosporin. And you see the remission rate was 60% in the rituximab group and only 20% in the cyclosporin group. So now you're seeing nephrologists being a lot more hopeful about using rituximab maybe more in our patients with membranous nephropathy, and we might be able to avoid medications like cyclophosphamide, which has some very severe side effects like infections for females, possibly infertility with the use of cyclophosphamide. So some severe side effects. So Savannah, if we want to, this is a break between nephrotic, things with more protein going into nephritic, things with more blood and hematuria, if we want to look at some of the questions.
Yeah, so I will just give a warning. Let's see, what time is it? It's 2:20. So we do have only 15 minutes left before we need to start wrapping up. Do you think we'll be able to get through all of those slides within that time and ask questions?
So nephrotic is more common than nephritic when it comes to things that we talk about. So yeah, it's some questions they have right now.
Okay. Let's see. Let me go. Oh, someone had asked if you'd be able to show that last slide again and maybe talk through it real quick.
This one?
Let's see, Shanna, is this the one you're referring to? I think, yes, this one.
Yeah, this is the Mentor trial. So yeah, they looked at rituximab versus cyclosporin. Personally, I wish they had compared versus cyclophosphamide, which is more the first line therapy for membranous, but they went cyclosporin. and it looked at partial remission or complete remission.
Okay.
And yeah, it was 60% versus 20%. Rituximab was a lot better. They did 2 doses of rituximab, and they used very little doses of steroids, whereas in cyclosporin group, we use a good bit of high-dose steroids.
Okay. Thank you so much.
This just came out in the New England Journal of Medicine 2020. And actually, this is actually the treatment I went with for my patient with membranous that I was just treating. We went rituximab, especially in the middle of the pandemic with COVID-19. Was trying to decrease some of the side effects and with possible cyclophosphamide.
Yeah, thank you so much. All right, this is a great time for everyone to begin putting your questions in the chat. I do have a question for you, Dr. Cobb, which is it possible for a patient to have a biopsy that results in 2 different diagnoses, like, for example, FSGS and IgA nephropathy?
Okay, so what you see on the biopsy, the pathologist has to read it out. And it might say that this patient had focal segmental glomerulosclerosis, or it might say global glomerulosclerosis. That's the amount of scarring they have on the biopsy. But the primary thing, most likely, is the IgA. Or the other way around, you might have FSGS on the kidney biopsy, but then you have some staining for IgA or IgM, which is unusual, and that would make you think this might be a secondary cause of FSGS. Does this patient have lupus? Does this patient, instead of having FSGS, have IgM nephropathy? So sometimes you can see a mix, and the nephrologist sometimes the nephrologist even have to call the pathologist and say which one you think you see more of, or which one is the predominant thing that we need to treat, because the treatment could definitely be different between IgA versus FSGS.
And that seems like a good reason to see someone who is a specialist in these things, because it can be very complex. Someone did say, Shanna said that her son is on cyclosporin right now, and she was thinking of changing his meds to rituximab, and she wanted to say thank you.
For membranous?
I'm not quite sure.
Oh, okay. But yes. Also, for younger patients, also, there's a lot of promising data with minimal change disease in the pediatric population with minimal change disease also.
Okay, and she did say her son is FSGS.
Okay.
And then I had a question when you were talking about treatment options for membranous and how you had recommended dietary changes, like lifestyle and dietary changes, to see what happened there. How effective do you think that is for patients with membranous or other forms of nephrotic syndrome?
Well, all of the nephrotic syndromes, I should say, edema, swelling, could definitely be worse with sodium intake. So we definitely tell patients to cut back on their sodium intake. If you have high blood pressure associated with your nephrotic syndrome, you need to cut back on your sodium intake. Also, exercise definitely helps when it comes to blood pressure control in these patients. And membranous is one of the few that we know, because 20 or 30% get better on their own, that we go more for the lifestyle modifications and blood pressure control, instead of throwing high doses of immunosuppression at all the membranous patients right away. So we definitely do a lot of blood pressure control and diet modifications in those patients.
Yeah, thank you. And then one last question before we head off into the next section, which is, if one of these patients has been considering a clinical trial and is interested in clinical trials, but their doctor has never brought it up, how would you suggest that they do that from the perspective of a doctor?
Okay, so it depends on their doctor might not be involved in clinical trials, or their university or healthcare system, if they're in private practice, might not be associated with clinical trials. But I actually will talk about it at the end. There's some sites you can look at to see clinical trials that are involved and which sites are being enrolling patients. I would have to say that the majority of my glomerulonephritis consults actually come from other nephrologists, private practice nephrologists, especially in like rural areas of Georgia, who do not feel comfortable seeing glomerular disease for glomerulonephritis patients, and refer to our clinic, because we're a specialty clinic, and seeing those patients. So a lot of times you can, they can maybe help you find a doctor who's enrolling in those trials. And I would have to say, I think the majority of doctors would not feel offended, and will at least want to talk it through with you.
Yeah, that's great. And I actually,
And if
one
that
more
person is
question.
offended, though, you might not have the great working relationship. You might have to find someone who's willing to, think about all options
Yeah.
and willing to discuss it with the patients.
That is a great point, Dr. Cobb. And also another great reason to check out our NephCure specialists list on our kidneyhealthgateway.com, because it is a really great list of doctors. I do have one more question from Erin. She said, with a primary FSGS patient that is responding to steroids, typically how long is this patient on high dose steroids before tapering, or just in general?
Okay, so that's the thing. So if you read most studies, it's try to get high doses in for at least 16 weeks or 4 months. And when I mean high doses, it doesn't have to be 60 or 80 milligrams the whole time. Because some patients, I have a patient right now, she just saw her for the first time like 5 weeks ago, got a kidney biopsy back already. She only been on high doses of steroids for like 2.5 weeks. And her protein and her symptoms have really improved already. But the issue with if you get the tapering, so I will start tapering, but I try to keep on what we call high dose, 20 or above, at least for 16 weeks or 4 months. But you don't have to be on the 60 or 80 milligrams the whole 4 months if you're responding already. And we try to do the taper, and we try to treat for FSGS for at least a total of 6 months. The thing with FSGS though, some patients might respond later than others. So you might be on longer than 6 months if you have a slower course of responding.
Okay, thank you so much. And we do have about 12 minutes before we need to end the Zoom call. So I will
No
hand it
problem.
back over to you for the next section.
Thank you. So nephritis syndrome. Usually this is more abnormal kidney function, high blood pressure, swelling, blood in the urine. They usually don't have as much protein as our nephritis syndrome patients. This is something I look at the urine of all my new patients, even though they don't have glomerular disease or we're not suspecting it. But these Mickey Mouse looking cells, they're not funny. We call them Mickey Mouse looking cells. That's usually a bad sign. These are dysmorphic red blood cells, and it'll be even if we got somebody we're not thinking about nephritic syndrome, I think about it after I see these funny looking red cells and do the workup. So case, 19-year-old female, she's a nursing school student, presents to a student health center with complaints of bright red urine. She has been having an upper respiratory infection for the past 2 days with a runny nose, sore throat, low-grade fever, no episodes in the past. She has a family history of a father with IgA nephropathy. So what will we do in this patient? Will we do a kidney biopsy, serum IgA, chemistry labs, and urinalysis, serological workup for secondary causes? We'll do all except for serum IgA level. We don't follow the levels in IgA, but we do a kidney biopsy, we get the labs and look at the urine and make sure we're ruling out secondary causes of IgA like infections. Commonest cause of nephritis in the world. So we talk about nephritis syndrome, things like FSGS and membranous are more common. But when we talk about nephritis or blood in the urine, especially in places like Southeast Asia, IgA will be number one. Second and third decade peak incident occurrence, I totally agree. I have a 30-year-old nurse who I'm following right now who has IgA nephropathy. It could be on the spectrum of just asymptomatic, little bit of blood in your urine to rapidly progressive kidney failure, needing dialysis. Prodrome, a lot of patients will say they have an upper respiratory infection symptoms, then they'll get sick. On the kidney biopsy, you'll see on the immunofluorescent, it was stained with IgA. About 50% of patients with IgA had a relative with IgA. Higher poor outcomes in IgA are predictors of outcome. Higher creatinine on presentation, males, older, hypertension, more protein in the urine. Treatment is very variable. If the patient is very mild, we can just get away with ACE inhibitors like blood pressure medication. More severe patients will need steroids, may need something like azathioprine or Imuran, or cyclophosphamide or Cytoxan. It can have blood in the urine, nephritis syndrome, protein in the urine, or both. Membranoproliferative, MPGN, it could be nephritic, or both. The body does not read the test books. It can be primary or idiopathic, it just happens. Complement levels, these are some labs we check, C3, C4. It's involved with your body's immunological antibody response. But complement levels are usually low in patients with MPGN. It could be secondary MPGN, like infections like hepatitis C, lupus, HIV, but we go concentrate on the primary idiopathic. Old school classification, when I was in medical school, we talked about type 1, type 2, type 3, MPGN or secondary cause of MPGN. But the new school is more immune complex associated. So we'll say this is MPGN associated with immune complex disease, or this is MPGN more associated with complement or C3 or C4 glomerulonephritis. All of this is rare, but the one that you'll see more often is C3 glomerulonephritis. And there's these special labs we can check C3, C4, and CH50. And some of these patients even need genetic testing. I had a couple of patients who had to go through this before. And luckily for us at Emory, we have a genetic clinic, where some places you might have to get referred to a genetic clinic if you have C3 glomerulonephritis, MPGN. And the prognosis related to the amount of protein. The more protein you have, the worse prognosis when it comes to MPGN. Treatment, treat secondary causes, but if it's idiopathic or primary, steroids, cyclophosphamide, rituximab, and for C3 glomerulonephritis, eculizumab is something that might be treatment option. There's some small case reports talking about that in MPGN. So why you need to see a nephrologist? For one thing, the diagnosis, the kidney biopsy. We're the only people who order kidney biopsies. Treatment options. We talk about your response to therapy, the side effects. I want all my patients to know about the major side effects. Now, I can't tell you about all 100 side effects that the pharmacy might have on the packet, but I can definitely tell you about the ones that patients see more often. So like steroids, weight gain, increased blood pressure, insomnia, hard time sleeping at night, feel jittery or hyped up from the steroid. Now, some of the patients like the hyped up. One of my male patients was mad when I got him off the steroids, and his weightlifting, he thought his body changed on the steroids, so he actually liked it. But most patients do not like the side effects of steroids. And even with the weight gain, special places like behind the neck, in the belly, in the face, like a moon or circular appearance of the face. Prograf, cyclosporin could be associated with raising the blood sugar or raising the blood pressure. We have to follow the levels on Prograf and cyclosporin. You can get jittery or nervousness, or if your cyclosporin or your Prograf levels are very high. Reason you see a nephrologist like myself, prognosis. We can tell you what your current kidney function is, and we can follow you and tell you how your kidney function is doing. If your kidney function is getting worse, or you're staying stable, or you're improving. Kidney disease complications, we're the expert on those. Blood pressure, anemia. Most people don't know the kidney makes EPO, which makes your bone marrow make red blood cells. So depending on your kidney function, you're gonna have anemia associated with your kidney disease. Cholesterol, as we talked about earlier, that with the nephritis syndrome and spilling protein in your urine, the liver ramps up the amount of cholesterol that's being made. So you need help with treatment of the cholesterol. Lifestyle and diet modification depending on your labs. I don't treat all kidney patients the same. So if you read renal diet or kidney diet, they'll talk about low potassium diet and everybody's low phosphorus diet. No, it depends on your lab and your stage of CKD. There are 5 stages of CKD, but you need to follow the nephrologist so I can tell you when to cut back on your potassium, when to cut back on your phosphorus. Now, I pretty much tell everybody to cut back on their sodium. If respond, I'll monitor for relapse. Some of my patients who are doing great, I just saw one of my patients, I only see her like every 6 months. She had FSGS, she had the chip variant, she responded well with steroid. But I want her to get a kidney function checked and see me at least twice a year. If your disease progresses, we talked about CKD or chronic kidney disease, disease education, like dialysis. Unfortunately, in the United States, the majority of patients on dialysis do dialysis in the center 3 times a week. We have a missed opportunity where patients do better with home therapies and peritoneal dialysis. I'm about 33% of my patients on peritoneal dialysis currently. Then kidney transplant. The proudest moment I have as a nephrologist when I can get somebody a preemptive kidney transplant. They go from seeing me in the clinic, get a kidney transplant, and never need dialysis. We talked, unfortunately, you don't respond to treatment. #1 cause of end-stage kidney disease or end-stage renal disease. A lot of names for the same thing, kidney failure. Diabetes, #1 in the United States. Hypertension, #2. But glomerulonephritis, all the things that we talked about today is #3. So it's important to get diagnosed, get treated so we can prevent you from going to renal failure. Future therapies, lipophoresis. You might Google this and you might see this come up. There's some talk about removing the lipids and certain things involved with like with FSGS and the cholesterol level goes up. It's limited research, but people are looking into it at FSGS and looking at it for membranous. Vertex, the one I'm involved with, and we're a site. So I'm the adult nephrologist, and we have a pediatric nephrologist at the Emory site who getting patients for the FSGS trial, Vertex. I'm really happy about this one. We think we know the gene that's associated with a lot of FSGS, especially in minority patients, but also actually treating the products that this gene mutation might be causing. There's multiple studies looking at possible new drugs, and that's what Vertex is about. So we're very excited about that. And please go to research trials, kidneyhealthgateway.com. It talks about all the kidney trials in this area. Make sure you also look at NephCure, also groups like AAKP, the American Association of Kidney Patients, National Kidney Foundation, NKF. They have a lot of material for patients, and we want patients to be informed. Informed patients, I think, do better. You know, you're supposed to trust your doctor, but you're also supposed to be a team where we talk about treatment options, what way you're going. It should be a team effort, so please educate yourself about your disease process. And this is actually for the Vertex. We're actually getting patients into this clinical research trial, and we're very excited. Find strength, give strength. This is very important.
Dr. Cobb, I'm so sorry to interrupt, but there's about 2 minutes left in the Zoom.
Yes, we're finished. I'm on the summit advertisement.
Oh, amazing. Well, if you have anything else to say, you can go ahead and then I can wrap up.
Or any questions, if anyone has any lasting questions on some of the nephritic ones.
Yeah, let me check in the chat. So it doesn't look like any questions came through. If questions do come through before the end, I'll just take them down and we can make sure we get to these people. After this, I didn't realize there was going to be so much great content to go over, but that is so excellent. I do want to, let me turn my video on. I do just want to say thank you to you, Dr. Cobb, for coming and speaking to us today. This is just jam-packed with amazing information. And it's coming through in the chat now. People are saying thank you so much.
Oh, thank you all.
Yeah, taking time out of your busy schedule. I also wanted to say thank you to our pharma sponsors that you saw on the last slide. They're all on there. We are so grateful. This summit would not have happened without your help, and we just want to say thank you. Our patients are indebted to you, and so are we, just for your kindness to our organization in advancing this really important work. Thank you, Dr.